Somewhere right now, someone is sitting in a doctor's office being told their MRI is normal. Their headaches are just stress. Their dizziness is just anxiety. That tingling in their hands is just poor circulation. And buried in their scan report is a single word that quietly closes the conversation. Incidental. But what if that finding wasn't incidental at all? What if part of their brain is sitting somewhere it was never built to be, pushed down, out of place, crowding the exact space where the brain is supposed to connect to the spine? This is Chiari malformation, and it might be one of the most misunderstood diagnoses in medicine today. Not because it's rare, but because it almost never looks like what people expect a brain condition to look like. Let's start with what's actually happening inside the skull. At the very base of the brain sits the cerebellum, the structure responsible for balance, coordination, and fine motor control. Below it is an opening in the skull called the foramen magnum. Think of it as the doorway where the brain connects to the spinal cord. In a healthy skull, the cerebellum sits neatly above that doorway with room to spare. In Chiari malformation, the lower part of the cerebellum, specifically two structures called the cerebellar tonsils, actually herniate downward through that opening, pushing into the space meant for the spinal cord. Here's why this matters so much. That same space is where cerebrospinal fluid is supposed to flow freely, cushioning the brain and spinal cord, carrying nutrients, clearing waste, moving in rhythm with every heartbeat. When the cerebellum crowds into that doorway, it can partially block that flow. Pressure builds where it shouldn't, and the nervous system starts sending out signals that something is wrong, even when no single symptom clearly points to the cause. This is exactly why Chiari is so frequently overlooked. The symptoms don't read like a neurology textbook. They read like a list of unrelated complaints collected over years, from different doctors for different reasons. Headaches at the base of the skull that get dramatically worse when you cough, sneeze, or strain. Neck pain that never responds to physical therapy the way it should. Dizziness or a spinning sensation triggered by turning the head. Numbness or tingling in the hands, arms, or face that comes and goes without warning. Balance problems that feel random, not consistent. Even ringing in the ears or a pressure sensation that shifts depending on posture. Individually, every one of these symptoms has a dozen more common explanations. Migraines, poor posture, anxiety, a pinched nerve in the neck, TMJ dysfunction. And that's exactly the problem. Doctors are trained to rule out the most statistically likely cause first, and Chiari is rarely near the top of that list. So patients often spend years cycling between specialists. A chiropractor for the neck pain, a neurologist for the headaches, a therapist for the dizziness, each one treating a piece of the puzzle without ever seeing the whole picture. There's another layer that makes this even more complex, and it's the piece most people have never heard of. In some people, Chiari doesn't exist alone. It coexists with something called craniocervical instability, or CCI. This means the ligaments holding the skull onto the upper spine are looser than they should be, allowing small amounts of abnormal movement between the skull and the first two vertebrae in the neck. Here's the critical part. Someone can have a mild Chiari malformation that on its own would cause zero symptoms. But if craniocervical instability is also present, that extra movement at the base of the skull can intermittently increase pressure and worsen the crowding, turning a silent structural finding into a source of daily symptoms that flare and fade for seemingly no reason at all. This single mechanism explains something patients describe constantly, almost word for word: good days and terrible days with no obvious trigger. Because the mechanical stress isn't constant, It shifts with posture, with movement, with exactly how that joint happens to be sitting in any given moment. There's also a connective tissue link worth knowing about. Conditions like Ehlers-Danlos syndrome, which cause joint hypermobility throughout the entire body, show up more often in people who have both Chiari and craniocervical instability together. If someone's joints have always been unusually flexible, double-jointed fingers, hips that pop, a history of sprains from very little force, and they're also dealing with these neurological symptoms, that combination is not a coincidence doctors take lightly. It's one they now specifically screen for. So how does this actually get identified? The starting point is a standard MRI, which can measure exactly how far the cerebellar tonsils have descended below the foramen magnum. But a standard MRI alone often isn't enough to see the full picture. A more specialized test called a CNE MRI captures the actual movement of cerebrospinal fluid in real time, synced to the heartbeat, revealing whether that flow is being blocked and by how much. For suspected craniocervical instability specifically, doctors may also order upright or flexion extension X-rays, images taken with the neck bent forward and backward, designed specifically to catch abnormal movement between the skull and spine that a standard scan, taken lying perfectly still, would completely miss. This is precisely why so many cases slip through undetected for years. If someone is never imaged in the positions that actually provoke the instability simply never shows up on film. The scan reads normal. The symptoms don't. So what happens once Chiari is properly identified? Treatment depends entirely on severity and on whether craniocervical instability is part of the picture. For mild, asymptomatic cases, many people need nothing more than monitoring over time. For symptomatic cases without instability, the standard treatment is a surgery called posterior fossa decompression, which creates more space at the base of the skull to relieve the crowding and restore normal fluid flow. But here's a detail that changes outcomes for an entire subset of patients, and it's the detail this video really exists to highlight. When craniocervical instability exists alongside Chiari, decompression surgery alone can sometimes make things worse. Removing bone at the base of an already unstable skull can reduce stability even further. In these more complex cases, addressing the instability itself, sometimes through targeted stabilization of the upper cervical ligaments, may need to happen before or alongside any decompression procedure. This is why an accurate, complete diagnosis matters so much before any treatment decision gets made. Getting this sequence wrong isn't a minor setback. Research on complex Chiari cases suggests it's one of the leading reasons decompression surgeries fail to resolve symptoms, and sometimes require a second, more complicated surgery to correct. If there's one thing to take from all of this, it's this. If someone has been told their MRI shows an incidental finding and they're still living with headaches, dizziness, numbness, or symptoms nobody has been able to fully explain, that combination is worth asking more questions about. Not to self-diagnose from a video, not to panic over a Google search, but to walk into the next appointment already knowing precisely which questions to ask and which imaging actually needs to be done to see the full picture. Not just part of it. Understanding your own anatomy was never about replacing your doctor. It's about being able to advocate for yourself in that room, with the right words, when it matters most. If this kind of breakdown helped make sense of something confusing, subscribe. This channel exists to make the body's hidden mechanics make sense, one structure at a time.